Hi, good afternoon, everyone. Welcome. Thank you for joining us today. I see everyone coming in here from the waiting room, and the numbers are still going up quickly, so I'll give it a minute or so, but we have a good presentation for you today, a kind of special edition, given that, as you probably know, it is Aortic Dissection Awareness Week. So we have a lot going on, and I'm joined by both Meredith and Bella from the foundation. And then, of course, we have our speakers here today. This topic has been very popular in the past, and I know we have a lot of deep Dr. Prakash fans out there, so you're getting more of him. Um, Looks like everyone's filed in from the waiting room, so I will see if I can do a quick welcome screen here. All right. So welcome, as I said, it's Aortic Dissection Awareness Week. My name is Ellen Hostetler. I'm the Chief Science Officer for the John Ritter Foundation. And I'm just going to immediately ask Meredith to introduce herself and speak on this week and what we're hoping to accomplish, and the foundation a little bit too.
Well, hello. Thank you, Ellen. As she said, I'm Meredith O'Neill. I am the CEO of the John Ritter Foundation. Thrilled to be here with you and thrilled that it's Aortic Dissection Awareness Week. As many of you saw, we are partnering up with other organizations from across North America, like GATA and Marfan Foundation, and their subsidiaries like VEDS Movement and the Lois Dietz Foundation, as well as Aortic Hope and Think Aorta. So we are just so thrilled that we are shining a light on this often under-recognized and underdiagnosed condition. I was trying to figure out what I was going to wear today to this, and I went to go change, and I was like, wait, why? I'm going to go get on the treadmill because I myself had a type A dissection back in 2018 when I was pregnant. And I know I was terrified of working out for many years after my dissection. I would say for probably 4 years, I was really, really nervous to work out. And so I am personally extremely invested in the results that we will hear today from Dr. Prakash. I'm one of the many fans that Ellen mentioned as she did her intro. Um, we this week we are highlighting different families, different stories. We are asking tomorrow would have been John's 77th birthday. He passed away back in 2003, and tomorrow would have been his 77th birthday. So if you're so inspired, if you go to our website and click on donate, there is a place for you to donate $77 in honor of his memory. So I wanted to bring that up, but this isn't a special webinar that we have for this week, and we had so much interest. And like I said, I am personally very invested. So thank you, Ellen, for bringing this together. Thank you, Dr. Prakash, and just so thrilled to be with you here.
Amazing. Next, I'm going to have Bella introduce herself and talk a little bit about some of the services that we offer at the foundation that she herself oversees.
Hi everyone, I'm Bella. I am the Patient and Advocacy Coordinator for the John Ritter Foundation. My main role is to basically anybody who's reaching out to us, connect you with any resources or support that you're looking for. So I run our aorta advocate program, which if you haven't heard of it, it consists of volunteers from around the aortic community who are personally affected, whether it's themselves, their family members, or they've lost loved ones to dissection, have family history of aortic disease. And then I started a new program called Aorta Prep, which is you can meet with me virtually and help you prepare for an upcoming doctor's appointment related to the aorta. So those are the two main things that I help with. You know, I help connect people if you want to be involved with us. If you are looking for anything like genetic testing resources or a specialist near you, I'm one of the ones that also helps you with that. So you're probably been in contact with me before.
Bella is the resource queen, so she has everything and knows everyone. And all of that you can find on our website. There's a johnritterfoundation.org/support, has a form that you can complete. You can even say, I don't know what I need yet, and just start getting in touch with us there. To that note, we did have some questions come in about kind of personal medical questions, timing of surgery, medications, things like that. And unfortunately, we can't answer those in this kind of format. But if you would like to reach out to us one-on-one via email or that support forum, we can point you to the right resources to start with and things like that. We do not provide medical advice. You need to go to your own providers for that, but we can help you sort of navigate the scene. So if that was one of your questions, please feel free to reach out to us and we will get you on the right path to that. And with that, I think we're going to introduce Dr. Prakash and get started. I feel like we all know webinars by now, but just as a reminder, please do ask your questions. The webinar is being recorded and will be available on our YouTube channel. I'm about to turn the chat on, so you'll be able to write in that. You can introduce yourself, and thank you for being here today. So, one last, our disclaimer, which is also on our website and is on our YouTube channel, that in short, please do not take the information presented today as medical advice, whether by Dr. Prakash or the John Ritter Foundation. This is for educational purposes only, and of course, you should consult with your own treatment team before making any changes to your medical care. So with that, I would love to introduce Dr. Prakash. So he is a cardiologist who specializes in cardiovascular and adult congenital heart disease, thoracic aortic disease, bicuspid aortic valve, Turner syndrome, probably many other things that I am leaving off there because he does so much. He is also a member of the John Ritter Foundation's Professional Advisory Board. And for those of you who don't know what that means, at the foundation, we have a team of experts in aortic disease, cardiologists, geneticists, surgeons who review the information and resources we put out to make sure that that information is correct and up to date and beneficial to patients and clinicians too. So you can trust this information and feel as though it's coming from a trustworthy source. So that's what the Professional Advisory Board does. And Dr. Prakash is a professor at McGovern Medical School at UT Health in Houston. And we used to share a wall in our offices when I was there. So that's my little trivia fact. So with that, I will turn it over to him for this presentation. I know we're all excited.
Thank you very much, Ellen. Thanks, Meredith, and everyone at JRF. It's an absolute pleasure to work with you, and I hope that this is informative. What we want to do today is to provide some insights that we have learned during the almost 2 years that we've worked on an exercise study that was funded by JRF and has continued to help us guide patients in their questions about exercise. So we're going to provide some tools that we hope will help people start to exercise and answer some questions that we have dealt with over the years. With me is Randy Liu. He's a medical student who's worked with me on this project and has created some of the videos that you're going to see. There were several other students on our team, and so this is truly a group effort. In addition, the work that you see involved 3 different medical centers in St. Louis and Michigan, as well as Houston. So there were more than a dozen people involved in these studies, and I'm certainly just speaking for all the efforts of many people. So I'm going to talk about our exercise trial, give a rough outline of what we did. There's not time to go to it in detail, but I can answer questions. The main takeaways from the trial, and then tips for starting to exercise, some guidance that we developed based on the trial results. We'll go over a new brochure that we're developing for patients and a publication on exercise recommendations for people who are starting to exercise.
Dr. Prakash, sorry to interrupt,
Sure.
but can you switch the view? We're on the
I'm
presenter
sorry.
screen now. I mean, we can still see it, but
Is that better?
that's perfect. Wonderful.
Okay.
That's all.
So patients with thoracic aortic disease may often hear that exercise presents risks. And here are some common reasons that people might hear. Your blood pressure increases when you exercise. We know that high blood pressure is risky, so you should avoid exerting yourself to the point where your blood pressure goes up. There is no safety for many exercises, and so we can't really say what the risk is. This leads to a lot of uncertainty. You could have an aortic dissection when you exercise. There are case reports, and certainly there's a lot of fear about dissection risk. And of course, there are no clinical guidelines the way there are for other things like medications or even surgery, and that leads to a lot of anxiety. And for this reason and many others, we decided to study exercise so that we could try to create information to help fill in some of these gaps. We do know that exercise can improve your health. It can build fitness and endurance. This is true for many forms of exercise and many conditions. We know from many exercise studies that in studies of your molecules and health, it can decrease inflammation and stress in your body and reduce cellular damage. So it has cellular benefits. Overall, it is very effective to reduce anxiety and depression and is clinically indicated in some forms of treatment for mental health disorders. We also know that it can lower blood pressure in many studies over the years. There's actually a dose dependence in that for each extra hour of exercise you do over being sedentary, your blood pressure drops 2 to 3 millimeters of mercury. And we know that over a lifetime, this can add up to a huge decrease, up to 40% in your risk of cardiovascular death based on activity alone. And more recently and more exciting, there have been studies with patients and originally in animals showing that activity in patients with Marfan syndrome can actually reduce the rate of aortic dilation. And this is something that we're really excited about and hope to test in further trials going forward. So the goal of this particular pilot study was to, first of all, show that exercise after an aortic dissection, which is considered the riskiest kind of state for the aorta to be in, is safe and can actually be effective, both for its mental health effects and the blood pressure response that we would track throughout the clinical trial. And we designed this to be a year-long study. We enrolled patients in person, and we made the participants in this trial do a lot of things. They had to come for an in-person visit. They would sign a consent form, answer a lot of questions about their health and exercise habits, and then they would do a 24-hour ambulatory blood pressure test, which is a test that measures your blood pressure automatically every 20 minutes. At that point, we would randomize them into two groups. So about 1/3 of them got randomized to usual care. And what that meant is we gave them some instructions about being healthy, how much exercise to get per week, a pamphlet that went through some information about exercise. But then they went to their regular doctors and they followed up at their usual visits for 1 year until they came back. The guided exercise group then went into a one-on-one in-person exercise training session where we actually showed them the exercises we're going to present here tonight. We did then one virtual check-in session with them at home where we had them model an exercise so we could assess how they were doing it at home. And then two virtual follow-ups where we would have them record their exercise habits and check in with them about any modifications they were making to the exercise. Both groups were then called back after 12 months for a final study visit where they'd fill out more questionnaires and do another ambulatory blood pressure. The goal here was to measure the psychological effects, the health effects, and the blood pressure effects of exercise over 1 year. So we enrolled a total of 93 participants, and about 2/3 were in the guided exercise and 1/3 in the usual care. This is the information that we had. The important thing from this slide is that the characteristics of the group of exercise participants closely matched the group of patients who come to our institutions with type A or type B dissections. They were in their 50s. They were majority male. About 2/3 to 3/4 had type A dissections. The rest had type B dissections, and they were both several years out from their dissection. And that's important because we didn't want to enroll patients right after the dissection when things are still changing and they might need surgery or other kinds of medical procedures. So the most important thing that we found is that exercise in this group of patients was very safe. So there were no aortic dissections over the year follow-up, no aortic operations, no one needed aortic surgery, there were no deaths. We did have one in-person exercise session that was temporarily paused because someone developed high blood pressure, but that person had their medications adjusted and they were able to complete the exercise session. There was one right iliac artery dissection in a guided exercise participant, but this occurred outside the context of exercise. It happened spontaneously when the patient was at rest, and it did not require intervention. So what did the trial show? The most important thing that we wanted to show is that moderate intensity home-based exercises are safe for most people with dissections. That participants frequently, we found that they frequently did modify exercise. Once they went home, we didn't tell them that they had to do it exactly the way we showed them. We showed them some safety principles, and they were free to modify it so that they can complete the exercises in as comfortable a way as possible. And then we asked them what they had done to make modifications for themselves. So we found that about 40% had major modifications due to frailty or joint pain, but most of them were able to persist and complete the exercises with the modifications. Afterwards, participants reported increased confidence to exercise. And we also found that a lot of people, even the ones who thought that they didn't have hypertension, actually did develop high blood pressure during exercise, and that this was not always predictable from resting blood pressure. But we could show that with ambulatory blood pressure, we are able to get more information about this, and that would be useful to guide treatment for these individuals. So based on this result, we developed some principles about beginning exercise with thoracic aortic disease. The first and most important thing is that you need to have a complete evaluation of your aorta and understand the condition of your aorta before you begin to exercise. The reason is that because many individuals have ongoing issues that need to be addressed and can present risks for particular types of exercise. So knowledge is the most important thing, and having a recent evaluation by an aortic specialist before you start an exercise program or increase one can keep you safe. The second is exercise techniques and modifications are extremely important because if you strain too hard during exercise, we've shown that not only can it increase your risk for injury, it can also raise your blood pressure, and we know over time that that can be deleterious. So maintaining a moderate intensity by making modifications and adjusting your technique, hopefully in consultation with a therapist or someone who's observing you, can often make a real difference. And we saw this in the one-on-one exercise sessions. When we observed and gave feedback, people often did do better with their exercise. They strained less, and we showed that that resulted in a lower blood pressure with exercise and the ability to complete the exercise without overly straining. And so this means that most individuals need to develop targets based on their personal level of conditioning and exercise goals in order to optimize their experience with exercise. So these are some questions that you might want to ask your provider before the exercise. If you have an aortic aneurysm, is it stable? Are you likely to need surgery on your aorta? If you're close to needing surgery, your doctors may advise you to postpone starting an exercise program or modify it significantly. And that's because that is considered to be a less stable situation where your aorta can change over time. If you have a dissection, what part of the aorta does it affect? And is your blood pressure controlled? And we can talk a little bit more about that in the discussion. But in general, for people with a thoracic aortic dissection, we try to lower blood pressure as low as it can be tolerated using medications that include at least a beta blocker. So if you're on those medications, it will affect your exercise capacity and your blood pressure. And that's important in terms of developing a strategy for exercise. So why did we choose an at-home guided exercise routine? The most important thing that we wanted to achieve here is to show that, first of all, that we could make it accessible to as many people as possible. As I mentioned, for the trial, we had people come in person because we wanted to take measurements of them while they exercised. But in real life, it's very difficult for people to travel to reach an exercise facility or a rehabilitation facility. Many people live far away, and it's simply not convenient. So we wanted something that people could do at home with simple equipment that you can easily obtain on your own or have mailed to you. We wanted to develop a consistent protocol that people could replicate at different sites, that we could easily teach people to do and have confidence that they could adhere to it. And we wanted to make sure that it was safe and flexible so that they could make modifications in the comfort of their own home and be confident that they could complete the exercise routine. So these are some principles that relate to what I just said. And as we'll emphasize in the actual exercises, it's very important to start at a slow rate and gradually increase the amount of activity. If you strain or increase beyond the level that you're comfortable with, that's when we found people were getting into trouble with their exercises and having difficulty completing them. And of course, you always should stop if something feels wrong. You know your body best. And if something is different, then that is an indication that maybe you're pushing a little bit too hard and you should back off, take a break. So these are the exercises that we created for the trial. We're going to go through them, and we've also created some videos that we're going to show. The three that are in red we'll have videos for to illustrate how we actually guided participants in the trial, and then tips for the others. The first is bicep curls. For these, we asked participants to select a weight that was comfortable to them. For the trial, we provided 5, 8, or 10-pound weights. Clearly, some people can use more than a 10-pound weight, but we wanted to find a weights that would work for almost everyone. And we started out with 10 reps per arm with a goal of increasing by 2 reps per week. The goal here was to control your breath, to inhale slowly while raising the weight and exhale slowly while lowering the weight, and telling participants, reminding them not to hold their breath. And this is a video by Randy Liu. Hopefully you will be able to hear it.
Welcome. In this video, we'll demonstrate a series of safe and effective exercises designed to support cardiovascular and overall physical health. The first exercise is bicep curls. Begin by choosing a dumbbell weight that feels challenging but comfortable. It can be 5, 8, or 10-pound weights. Stand with your feet shoulder width apart, arms at your sides. Keep your elbows tucked close to your torso. Don't let them drift outward. Keep your elbows at a 90-degree angle to start. As you lift the weight, inhale slowly and fully. Pause briefly at the top. Lower the weight in a controlled motion while exhaling slowly. Avoid swinging or using momentum. This helps protect your joints and ensures you're working the muscle effectively. Keep your wrist in a neutral position and make sure to breathe steadily throughout. Start with 10 repetitions per arm. Each week, aim to increase by 2 reps until you reach 30. If you choose to move to a heavier weight, reduce your reps slightly by 2 to 4 and rebuild back to 30 reps. If you are unable to perform the bicep curl exercise, we have 2 modifications you can use. If full range curls cause strain, reduce the angle of movement to 45 degrees rather than 90 degrees. If you feel any arm pain, reduce the amount of weight used and perform additional repetitions instead. If you have back discomfort, try bracing yourself against a wall or a bench in order to reduce tension on your back. A few reminders before the end of the video. Remember, inhale slowly while raising the weight, exhale slowly while lowering. Maintain control of your movement. Do not let your weight drop uncontrollably. Remember, you know your body best. If you experience any chest pain or shortness of breath, please stop the exercise and seek medical attention. Thank you so much for watching.
Okay, so that's one illustration of the type of videos that we made for each of these exercises. As we mentioned, there are modifications for each of these that we took from the individuals in the trial. Many of these modifications were things that people reported during that year. And so we collated these when we described the trial results. Okay, the second exercise that we created for the trial is the wall sit. This is an isometric exercise, and the reason why we created a combination of isometric, isotonic, and aerobic activities is we wanted to work different muscle groups, and we also wanted to measure the changes in blood pressure with each of these muscle groups, many of which have not been tested before in patients with thoracic aortic disease. So for the wall sit, it is generally performed in a stable position for up to 2 minutes. But as you'll see, there are many different modifications that can make this look quite different. And the goal here was to begin with a relatively short period and gradually build up 5 to 10 seconds at a time. And also, if you were not able to complete a full 90 degrees flexion at the knees, to increase the angle by 10 degrees per week. And we also told people not to do it to the point of exhaustion. If they felt shaky or tired, they were immediately to stop. So these were the precautions that we gave during the one-on-one session. And here is the video for the wall sits.
Welcome. In this video, we'll demonstrate a series of safe and effective exercises designed to support cardiovascular and overall physical health. The second exercise is wall sits. Stand with your back flat against the wall, feet about shoulder width apart, and slightly in front of you. Slowly slide down until your knees are near a 90-degree angle, or stop at a higher angle if you need to for comfort or knee health. Keep your back flat, core engaged, and avoid leaning forward. Focus on your breathing. Breathe steadily, inhale deeply, and exhale slowly. Never hold your breath. Start by holding for 10 to 30 seconds. Each week, add 5 to 10 seconds until you'll reach your goal of 2 minutes. It is okay to continue to increase the time past 2 minutes as long as you do not reach the point of exhaustion. Some modifications to the exercise include trying a higher position with less knee bend, or you can hold on to a sturdy chair or railing to improve balance and support. Here are some reminders before the end of the video. Remember to focus on steady breathing and do not hold your breath. Please stop if you experience any dizziness, lightheadedness, or chest discomfort. Remember that it is okay to stop at less than 90 degrees for the knee bend if this causes knee or back pain. Stop if leg fatigue causes instability or discomfort. Thank you for watching, and remember, stay active.
Okay. Again, these are the modifications that participants did most often. And in many cases, they were also taking 10 to 15-second breaks if they were unable to complete more than the 30 seconds at the initial attempt. The next exercise was hand grips. Hand grips are surprisingly effective activities. They can be done with minimal effort in many cases. And we wanted to test these because we could also test grip strength during the trial. So in order to to create the hand grip exercise, we used a dynamometer. That's this device here. It measures your grip strength. And what we did was ask participants to calculate their maximum grip strength by pulling on this device as hard as they could for 3 seconds, and then to adjust it to 40% of the maximum and hold it for the duration that they set. They started at 15 seconds and increased by 15 seconds per week until reaching up to 5 minutes if they were able to do that. So this hand grip exercise can be done in either or both arms, and it's been shown to have equivalent muscle recruitment and blood pressure effects to the wall sits. And here's some advice that we gave to the people in the one-on-one program. They were able to reduce the intensity of the grips or decrease the time if they developed hand or wrist pain. And here's some modifications that they used. Most commonly, they reduced the grip strength and they braced the elbow on a chair or table for support. The next exercise that we asked participants to do was leg raises. This shows a 2-leg raise at the picture on the right. The goal, they could also raise one leg, starting at 1 to 2 minutes, and then increasing the time or the distance raised over the course of the study. And we advised them to use a yoga mat or pillow for back support. We had mats in the training room. And in this case, they could start with a single leg for 10 to 15 seconds, increase the time by 10 to 15 seconds per week until they reached a target of 2 minutes. And then after they reached 2 minutes, they could increase the leg raise by 1 inch every 2 weeks. So they would document these things in their exercise diary. So here are the modifications. one leg instead of both legs. They could bend their knees. If they bent the knees, we asked them to gradually straighten one leg over 3 to 4 weeks. And if they started with one leg, we asked them to try to raise both legs to a small degree, usually 1 to 3 inches, and increase up to a minimum of 6 inches. Continuous breathing is key for this exercise as well. And then the most common issue with participants was back pain, and they were able to modify that by either decreasing the amount of leg raise or taking a break. The next exercise, which we'll illustrate with a video, is a treadmill. And the treadmill was a special challenge because not everyone can access a treadmill. We also allowed stationary cycling, which we'll do last. For the treadmill, we asked them to do 5 minutes of a warm-up period, 10 minutes or more of the exercise phase, and then 5 minutes of a cool-down period. When we were adjusting the treadmill in the lab, we started at a walking pace of 3 miles per hour, increased during the exercise phase, and we asked them to increase the miles per hour and the incline over each week by the amount shown. And then the ending pace equivalent to the starting pace with 0% incline for the cool down period. So these are the modifications: increasing the incline by 1%, the target speed by 1 mile per hour, and exercise time by 1 minute, with the target of getting 20 minutes in the exercise phase, or 30 minutes overall. And here's the treadmill.
Welcome. In this video, we'll demonstrate a series of safe and effective exercises designed to support cardiovascular and overall physical health. The next exercise is treadmill walking. Before you begin, locate the speed and incline controls on your treadmill. This will vary based on your treadmill model. Locate the emergency stop button. If you feel overly fatigued, please remember to press the button to stop the treadmill. This stop will be sudden, so hold on to the rail in front if you use the button. Begin with a 5-minute warm-up period at a comfortable walking pace. You can warm up either with no incline or at an incline of 3%. Note down the speed you began with. At this point, begin the exercise phase by increasing your walking pace by half to 1 mile per hour. Continue at this pace for as long as you can. Note down the speed at which your exercise phase is at. You can increase your pace by up to 1 mile per hour per week, and you can increase your incline by 1% per week. You are aiming for a target exercise phase of 10 minutes with a 14-degree incline. Once complete, perform a cool down for 5 minutes at the same speed that you began at, but with no incline. If you are able to, you can extend the exercise beyond 10 minutes as long as you do not feel any discomfort. Stop immediately if you feel chest pain, dizziness, lightheadedness, or extreme fatigue. If the exercise feels too hard, take a 5-minute break. When you are ready to begin again, lower your speed or incline. Some modifications to the exercise include walking with no incline or reducing your speed if the pace feels too intense. Use the handrails only for balance, not to support your weight. Remember, consistency is key. A couple of reminders before the end of the video. You will begin with a 5-minute warm-up before continuing onto a 10-minute exercise phase and ending with a 5-minute cooldown. Please refer to the graphic on the screen. Your exercise pace should be at least 1 mile per hour faster and 1% steeper than your warm-up at first. Do not alter your warm-up pace from week to week. You can increase the speed of your exercise phase by 1 mile per hour per week and increase the incline by 1% per week. Take a 5-minute break if the exercise is too hard and restart at a lower speed and incline. Thanks for watching. As always, stay active.
Okay. The key here, very similar. We asked people to choose either stationary cycling or treadmill in the trial. So we had very similar modifications for the cycling, except here it was based on the resistance, which is in watts. And we asked people to increase their resistance by 5 to 10 watts every week to 2 weeks, and to maintain a moderate pace. So here they could increase the watts or the time to build up to a similar time of 20 minutes for the exercise phase. And otherwise, the advice is very similar to the treadmill. And you can see that the phase warm-up and cool-down phase that we were advising is also very similar. Moderate intensity here is based on consensus of 150 to 200 watts, which you can set on the you can read on the machines, and most people are able to maintain that with the relative ability to maintain their cadence of their voice or maintain a conversation with slight breathlessness, indicating moderate exertion. And these are some of the things that people had done. Recumbent bikes are very popular because they avoid back strain. So a lot of people did use recumbent bikes, and many had decreased the resistance if they became winded during the exercise. So what we observed from all of these experiences and the feedback that we got is that it's very important, especially if you are contemplating a new exercise or more intensity, to consider a trainer or a therapist, because these are individuals that can provide a similar function to what we did in the trial: observe individuals, gather feedback, and provide corrective instructions during exercise. This is particularly important for some of the activities that involve isometric or isotonic activities where you're contracting muscles, because they can remind you to breathe normally. And that, we showed in the trial, can prevent you from developing high blood pressure. So this combination of guidance, feedback, and promotes safety and also increases confidence to engage in exercise, which is what we observed in the trial. And you can find a trainer or therapist near you by contacting the American Physical Therapy Association. Texas and other states have their own state therapy association. And the Ehlers-Danlos Society actually has an extensive network of therapists that for which they certify in training for musculoskeletal conditions that overlap with heritable thoracic aortic disease. So there are resources out there for people who are wanting to start exercise, but have a little bit of a stronger layer of safety. And then this is a pamphlet that we use to summarize what I just showed you in the video. These are going to be available to participants beginning at our location, and we're hopeful that we can modify them to make them available across clinics across the country for individuals who want to start exercising. It summarizes a lot of the things that we discussed in this presentation, and it goes through each exercise with the standard technique recommendations and modifications that we show. So it should provide a handy guide for people who are unfamiliar with some of these exercises, but may want to start and be able to assess some of the same factors that we discovered were effective in the clinical trial. And the other last bit of information is that we are developing consensus recommendations for trainers or physical therapists who work with patients with heritable vascular diseases. We used what's called the Delphi method, which is bringing together experts from across the world. Most of these are professors of physical therapy schools or occupational therapy schools, and then as well as researchers and clinicians who treat aortic disease. So the combination of this group, which is very unusual to get together, was thrilling, and we learned a lot from each other. But I think that we were able to put this in terms that therapists understand, which is the most important thing. And this would hopefully, when it's published next year, become a useful source of guidance to educate therapists that you might work with for individuals who need support and training and feedback. And I'd like to acknowledge all this work. Obviously, a lot of what you saw was Randy's work with the videos. We also had illustrations by Chris Akers, our professional illustrator here in McGovern. And I have to thank Carmen David and the aortic athletes as well, because a lot of their feedback was instrumental in getting the trial off the ground. So thank you, and I'll take any questions.
Fantastic. That was very exciting, and people seem to enjoy it and say this is very valuable information. So thank you for sharing. We had 2 quick questions, and then I'll move briefly to the ones people sent in ahead of time. Bella, actually, do you want to address these ones to Dr. Prakash while I pull up the ones that people sent ahead of time?
Sure. So one of the first questions we got is, will this brochure, what you just showed us, the exercise, be available to us? So I know that you mentioned that the hope is to get it distributed to other clinics. Is there something in the meantime that we can do to share the brochure?
Well, I think I would like community feedback about the brochure. We'd like to make sure that, first of all, people find it's valuable, understandable, that the information in it is useful. So before we distribute it, obviously, I want to get a lot more input from both JRF, but everyone else who is interested. And that's why it won't be available immediately, but I want input so we can decide how best to do that. But from the community, I think that would be great.
Yep, thank you. And I would say once it is something that's available for distribution, the foundation, we will be sure to put it on our website, distribute it on our social media and via our newsletters. So we'll make sure that, if you're a part of the JRF following, you'll get an announcement when it becomes available for you all to have and to share with your physicians. And then we have one specific to pickleball. So it says that her daughter enjoys pickleball. Her daughter is 43 and has an aortic aneurysm that was 4.0 centimeters last year, but is now 4.3. Should she enjoy continuing to play pickleball?
Yeah, so one of the things that we look at is how stable is your aortic condition. If your aortic condition is changing, either your aneurysm is enlarging or you may have a new change where you had nothing before, then that may not be stable. And so before you continue or increase an activity, the recommendation would be to go to your clinician, make sure that you understand what's happening, take some steps, maybe modifying medications and so forth to make sure that that is being addressed, and then reassess everything. So I always say that in this trial, the one thing that stood out to me is that everyone was carefully vetted in this way. And that is the caveat. When we say that exercise is safe, we mean for people who have had recent evaluations and were shown to have stable disease, because that was the criteria for the clinical trial. We can't say the same thing about people for whom that was not true. And so that's what I want to emphasize based on our current data. Obviously, we want to get more information about how important those elements are in future studies, but that's what we can say right now.
And a question, I think we might get a lot about specific activities or exercises that people enjoy in sports. So could you, the recommendation about the breathing and the being able to have a conversation, would those still apply to sports activity?
Yeah, so a helpful way that many of us think about this is to divide sports into recreational versus competitive. So recreational being your weekend activities with friends, casual, competitive being on a team where you're trying to win, where there's someone's keeping score. Those are two different levels of the same activity, and we generally draw the line at competitive when we talk about moderate versus intense. Okay, so a competitive game is not considered on its face to be a moderate intensity activity. It's considered high intensity. And those are the kinds of activities we specifically avoided in this study. We can't speak to the safety of those activities. I just want to point that out, that does not apply to what we were just talking about.
There's a couple more here, Ellen. Do you want me to go through them and then you'll take the
Why don't we kind of go back and forth so we can
Okay.
get to a good mix of both.
Okay.
So we had two people write in, one person who has Loeys-Dietz syndrome type 2 and one person who has VEDS. They're both asking essentially the same question, which is if you have these specific diagnoses within the broader, umbrella of aortic disease, how do you know how specific you have? Do you need exercise recommendations specifically for people with Loeys-Dietz, specifically for people with VEDS? Can you rely on general information? One person rightly pointed out here that isn't most research done in patients with Marfan syndrome. So that gets to a good question about research and how we can apply results to broader groups.
Yeah, so what I would say is that it's not so much the diagnosis or underlying gene, it's really the specific condition of your aorta and your other blood vessels that determine what may be safe or advisable for you. And that's one of the reasons why we said, a thorough evaluation prior to exercise, because that's not only the aorta, it could be the arteries in your neck and the arteries in your groin. And sometimes they're changing. And then exercise in those areas may not be advisable for you. So that would be more important for people with LDS and VEDS who are more likely to have changes in those other arteries than perhaps someone with Marfan syndrome. But everyone is going to be unique. And so that's why what we're saying is that you must personalize. And so you can't go by general guidelines. You have to really understand your situation and based on that, be able to draw conclusions. That requires some shared decision making with your doctor and having someone to follow these guidelines with you. It's very difficult to do by yourself, and that does lead to a lot of concern. But I think that if our goal is to publish these as guidelines that involve both the clinician and the patient making a shared decision. I think that's the future of this and would make the community the safest and most informed about exercise decisions.
And probably confident and comfortable with those decisions rather than feeling like I have to follow this rule they told me and I don't know why. And one of the person with VEDS actually wrote that they have stable dissections in 3 different arteries: splenic, iliac, celiac. So they said, "Will I never be able to exercise again because of this?"
The answer is we had a lot of individuals that had extensive dissections and had surgery, and they did fine. So the answer is many people with dissections are able to recover and exercise following some of these principles, and we hope to show that even more going forward.
So this is a big one about weight limit. In the trial, was there a weight limit on dumbbell exercises that was studied?
Yeah, so we allowed people to choose either 5, 8, or 10-pound weights. We actually mailed them to them. So we knew that they were all using the same weights. And then we had them chart their repetitions, how they changed week to week. So everyone used kind of the same range of weights. They would choose them based on their initial comfort level. And they were allowed to go up. So I think we did actually send larger weights to some folks, but most people stuck with the same weights. They just did more repetitions through the trial. So
Do you have any?
yeah,
Go ahead.
go ahead.
I was gonna say, do you have any comments on lifting weight restrictions for people
Yeah,
who might go to the gym?
that comes up a lot, and it was one of the reasons why we wanted to eliminate that as a factor in the trial because there is so much variation on the advice people get. Um, in clinical practice, what I tell patients who ask about weight limits is that you can lift the amount of weight that is comfortable for you without bearing down or feeling pressure in the chest or abdomen. And the reason I say this is because that number can be very different for a 90-pound woman than a 250-pound man who might feel that 20 pounds is nothing, right, for them to lift, whereas that could be an overwhelming amount for the 90-pound woman who has not done that before. So everyone is going to come up with a different number. And even more importantly, as you exercise and develop your fitness and strength, that number will actually go up, and it should go up. That means you're making progress. That's what exercise is for. If we just gave everyone one number, then we would be freezing them in place, which is not a human activity that we can understand. So that's why weight limits make no rational sense in exercise.
If Meredith is still here backstage, maybe you can just pop in to share your personal experience about how your exercise limits or abilities have changed since you. Oh, I see you.
Here I am. Yes. So like I mentioned at the beginning, and as Dr. Prakash knows, I was really nervous to work out after my dissection. And so I'm very lucky. I was able to work with a trainer. So these videos are basically your personal trainer, right? Somebody who's there to help you. And when I first started, the effort of doing weight training was hard, right? So I'd start at really low levels of weight training, and it's not like I'm doing these crazy weights or anything, but obviously over time my muscles have gotten bigger, right? And my abilities have gotten bigger, and so something that Dr. Prakash and I have talked about before that I hope you guys, because if you guys see, I have this workout ring, right? Like I think a lot of us have these little devices that are helping. And he said, make sure not to rely on that too much. Like, don't forget that you're special. You're on a beta blocker. So, like the heart rate monitors, like if it's not saying that you're in your aerobic phase, it could be because you're on a beta blocker. So, just think about how much effort you're putting into it. And so, my trainer and I'm still going to my trainer. Again, I'm very lucky to be in this, but I know, and I'm not afraid to tell her, hey, I'm feeling like it's a lot of effort here. And so we'll either lower or take a rest. And if we're doing things like planks or something, again, it's all about effort, but I do take more rests when doing things like that. So I have definitely increased from when I started this workout journey to now. It's just natural and I feel really comfortable with it. Did that answer your question, Ellen?
Yeah, that
Yeah,
was
no,
perfect.
build on something that you said, Meredith, there. So we do not rely on heart rate zones, which are commonly used in all kinds of videos that you see about exercise. Because if you're on a beta blocker, like she said, many times your heart rate won't reach those zones, but you could be quite intense in your exercise. Your heart rate response will be blunted. So there is an alternative way to do that, and it's called the rating of perceived exertion scale. Some people call it the Borg scale. It's basically a scale that you create for yourself, where let's say there you imagine 1 to 10. 10 is the hardest exercise you've ever done in your life, and 1 is just walking to get a beer out of the refrigerator. So you want to be in the 4 to 6 range, somewhere in between there, where you can carry on a conversation, but maybe a little short of breath. You're not so out of breath you can't talk, but you're not speaking uninhibited. So most people can find that for themselves. And as Meredith said, that will change, or actually, you'll be able to do more and stay in that zone over time because your fitness level goes up. So it's actually, you can actually see that. And I think that's very affirming to people. At least that's what we found in the trial. Once people realize, hey, I'm doing this and I'm making progress, it gives you a whole different level of confidence and a different perspective on exercise.
Yeah, absolutely. So I encourage you to look up from your devices of while you're working out, and really just listen to your body. It's what we always talk about, right? In this community is listen to your body no matter what, right? So listen to your body. For me, one of the things is like if I feel like I can hear my heartbeat in my ears, I'm just talking like a survivor, right? If I feel like I can feel my heartbeat in my ears, that's when I start slowing down. For me, that's like a really good thing that I'm like, oh no, I don't like this. And so I slow down. Or if my face is getting red, or if you're exerting too much, guys, like you're smart, but I know that fear is a big part of it. So don't be afraid to push yourself. Just don't push yourself too hard. You know your body the best. Dr. Prakash is the expert, but you're the expert on your own body. So make sure that you know that you have the power. You do. You have the power to protect yourself. And I really encourage you not to let the fear of working out um, keep you from working out, because that is where I was for a long time. I was gaining weight. My mental health wasn't great. And so this perceived exertion, I can't remember what you just called it, but the exertion, I'm just going to call it the exertion, I think is really, really key. And, there's not going to be a list of exact things that you can do. There's not, you need to know your own body and know that you have that power. And I know that's hard because aortic dissection is your body betraying you, right? Like out of nowhere, it's betraying you, or an aneurysm, something's happening to you that you have no control over. This you have control over. You know how much exertion it is. Your body won't, most likely will not betray you. I'm not going to say won't, that's a blanket term, but just yourself and remember that.
Thank you for sharing about your own experience there.
Yeah, that's
Uh,
really great
yeah.
advice.
I think it gets to something too when Dr. Prakash was talking about shared decision making. You just mentioned mental health, physical health. There are risks to being sedentary too that we often don't think about or talk about, when considering should I exercise? Is that safe to exercise? But there are also risks, many risks that, all people experience, whether they have aortic disease or not, if you're for your cardiovascular health in general from being sedentary, correct?
Yes, I mean, it affects every part of your body, not just your mental health, but your bone strength, your joints, how flexible you remain, and how pain-free you can stay as you get older. All of us develop some joint pain, but it can be much worse for certain conditions, and exercise is proven to decrease that over time. So your quality of life can greatly improve with exercise.
And and Dr. Prakash, if I can just bring up one more thing, because I keep seeing people asking about specific exercises. What can I do? What can I do? What can I do? And I think it's important just to say again out loud, and you can completely tell me if I'm wrong here, but it is person dependent. So, can you do push-ups? Well, how good are you at push-ups? I have to do push-ups on my knees, right? That is the exertion that I can do. But I've
Yeah.
never been the person that can do full-on push-ups. So I'm not the right person to ask if you can do push-ups. So it's based on where you are and your fitness level. Now, if I really wanted to focus on it, I probably could get to a full push-up. It's just not a place that I spend my time. So is that correct, Dr. Prakash, when we're talking
Ab-
about exercise?
Absolutely, Meredith, that's a really important point. And it's also important not to set unrealistic expectations. You want to start at a place where you feel comfortable. And if that means doing an exercise that you think is maybe it's too boring, it's not really exerting yourself. Don't think like that. And it's starting out at a slow pace is really the key, and then you can build up from there, but you have to start somewhere. I think that people have um, put a lot of pressure on themselves, and that can also make it scarier because you then feel like you're failing, and this is not about failing, it's about starting something new, which is exciting. I think it's the opposite.
I love that. Yeah, it is exciting. And hopefully you're setting behaviors in place that you can modify and change throughout your life as we age, have different physical needs and times of our lives. And I love it when I'm out hiking and I see people coming the other way who are, in their 70s and 80s and they've got their walking sticks and they maybe aren't going at the speed they used to, but they can still be out and enjoy nature and get exercise in. And I hope that's me someday.
And if I could bring up one more example, I know we're at the end of time, but just I've never been a runner. That is not who I am. So if I tried to go out tomorrow and do a marathon, that is not a good idea. That is a terrible idea, actually, and probably not good for my aorta, Dr. Prakash. However, this year we have a couple of people that are running the New York City Marathon who have had dissections. They've gotten clearance and things like that, but they've built up to it. So again, I can't say yes or no, you can do push-ups. Like yes or no, you can do a marathon. It is person specific. So Jack Crow, if you're on here, Jack Crow can go run a marathon because he's worked up to it. Meredith O'Neill will not run a marathon because the perceived exertion. Meredith O'Neill won't really run a 10K. The perceived exertion for me would be through the roof. So I just wanted to bring up another example of there's not going to be a rubber stamp on all of these things.
And a
I
pertinent
think
point there too is Jack was a many-time marathoner before
Of
he
course,
had a
yes,
dissection.
yes,
So
yes.
this
Yeah.
is his norm. Sorry, Bella, go ahead.
it's okay. I just wanted to comment. Also, perceived exertion is not what you think you can do. It's when you're doing the exercise and you're judging the level of exertion that you're doing to do the exercise. So it's while you're actively doing it and you're figuring out what level of exertion I'm doing. So if you don't, it's not that, oh, I don't think I could do a push up because I'm going to be exerting too much. Try a push up. Start maybe with the modification if you're not a push up person like Mare, and then you can there gauge the level of exertion it would take to do that exercise.
Really great
That's an
And
important point. Yes, and you can dial up or down depending on how you do with your first attempt. That is just the beginning. There are many ways, as we showed, to modify every exercise, and there are many times people who thought they could never do something would start with a modification and gradually increased to the point where they were doing a full rep and maintaining that same rating of perceived exertion.
I do want to address one of the questions that we have. We did talk about, the heart rate and how the beta blocker, if you're on one, might kind of block the heart rate from going up. It's doing its job. But how can you tell what your blood pressure is while exercising? Because you did talk about measuring while exercising in your lab. And how important is it to keep it at a normal level during exercise? So can blood pressure go up during exercise? Is it safe? Or would it not be safe?
Yeah, so one of the things we did during the trial when we were measuring blood pressure is we tried to determine, can we predict blood pressure responses? And what we found was that if individuals maintained that moderate level and they were not straining and they did not exercise to the point of exhaustion, we didn't have any high blood pressure readings in the trial. So blood pressure does go up, but it usually goes up to a small degree. It plateaus and then it drops as soon as you stop the exercise. The times when people had very high responses in the trial were either because they had previous evidence of uncontrolled high blood pressure, like in their 24-hour blood pressure test that we did at the beginning of the study, or they were doing the exercise by holding their breath, bearing down, or they were red in the face and getting exhausted. So when they reached the point of exhaustion, we noticed that their blood pressure shot up. And that's why we created these principles, because they correspond to the safe zones for blood pressure in our clinical trial.
Do you have any others, Ellen, from submitted?
I think we handled most of them. Probably not every single one of them. I apologize, but we are already 4 minutes
We're
over.
Yes.
So we have to let Randy and Dr. Prakash go. But if you have a question that wasn't answered that you feel we can help with, or Dr. Prakash can help with, you can reach out to us and we'll do our best. If it's one of these, can I do XYZ, then of course we may not be able to provide this specific advice on that, but we can share where you can get started doing that work. And of course, if you need help finding a team that you can trust to have some of these conversations, it's clear that everybody is very interested in talking about this and it brings their own perspective. And, I just feel like we can all learn from each other here. So I love that. Bella, do you want to say anything about any of the meetups real quick? The next one maybe that's happening, or that there are some, where to find the info?
Yes. So we do, as part of the aortic dissection awareness week, we are hoping to facilitate connections between the community. So if you've never met somebody else that's personally affected by aortic disease, we're having some of our aorta advocates across the country host meetups throughout the week. So if you go to our website, go to upcoming events, there is a specific post about the cities that the meetups will be in. We've already done the one in Colorado. And then I think there's one today, if I can't remember off the top of my head, in Sacramento. And then there'll be one in Houston on Friday, one in Chicago on Saturday, one in just outside of Boston on Sunday. So if you want to come out and meet one of the aorta advocates, meet somebody else who is affected by aortic disease, you're welcome to go out and say hi. You don't have to stay there for the whole time. Some of them are also part fundraisers. So if you would want to go out and you don't want to talk to anybody, you could still get some food. And some of the portion of the sale for some of the fundraisers will go to the JRF. So all that information is available on the website.
Great. Thank you. And of course, I'll try to have this recording up within 24 hours on our YouTube page. And just big thank you to Dr. Prakash and Randy for doing those excellent videos. Those will live on, I'm sure, and haunt you for forever. Your voiceover is there. You'll be hearing that in the background. And thanks, obviously, to Bella and Meredith for joining me for today. Any last topics before I sign off for us?
If you're not following us on socials, make sure to do that. It's where we really try to get you the most up-to-date information. It's the fastest way. So if you're on socials, follow us.
Sounds good. All right. Thank you again, everyone. We'll see you
Thanks,
soon.
everyone.
Thank you.